So thank you, Joan. Thank you, Alex. We're now going to move on to session 4, which is site change again. So this is looking really at the way forward post-COVID and recognising the fact that people are now living with secondary breast cancer. And so is some of the terminology used really quite inappropriate? And we've got 3, again, excellent speakers for this. We've got Dr. Chris Twelve, who's an oncologist from Leeds, and I went to medical school with him a long time ago, but that's another story. Alfred Neugut, who is Professor of Cancer Research and Epidemiology at Columbia University Medical Center. And we've also got Professor Mike Dixon, who is a breast surgeon up in Edinburgh. So starting with a mini panel with Chris and Alfred.
So I guess that's me starting. Okay, thank you. Thank you for that rousing introduction. Good morning from New York. So let me start by saying this is a lovely panel. I enjoyed listening so far. Let me say that I think what's very important is how we communicate. I think all of us can appreciate that. There's a lot of money being invested besides drug development, how physicians and healthcare workers communicate with their patients. I'll give as an example, something that I've been interested in is, for example, should we say to patients, the risk of recurrence of your tumor is 20%, or you've got an 80% cure rate. Which will a patient appreciate more or react to better or understand better when she thinks about how to react to how to be treated or what to do about her tumor or how will it make her feel. And the truth is that hundreds of thousands of dollars in research money has been invested by the government in analyzing that question. And if you're curious, the answer is the answer to that research question is it depends on the patient. Sometimes it's better one way, and sometimes it's better the other way. So the truth is that communication is an important part of what we do in oncology. And that brings me to the next point, which is that nomenclature, the words that we use, are very important. And I would give in this talk, I hope, 2 examples along with Chris to discuss. The first is the use of the word palliation. A new specialty has arisen, I think, in the last 20 years. I've been an oncologist for 40 years, but in the last 20 years, palliative care has arisen as a specialty. It's a wonderful specialty. I love it. It relieves me and my colleagues of much of the burden of taking care of many of the supportive care issues with my patients in terms of caring for some of the supportive care for them. One issue with that is when to refer a patient to palliative care, a patient with metastatic breast cancer. You've been all using the term secondary breast cancer. I'm not actually sure we don't use that term in America. I'm not actually sure what it even means now that I'm listening to the panel use it, but I assume it means metastatic breast cancer. But So in that regard, my colleagues are very reluctant to refer patients to palliative care physicians because patients are reluctant to go to them because they think if you're being referred to a palliative care physician, we've given up on you. And the truth is that as a result, patients are referred very late in the course of their disease to a patient when they're very near the end. And I think that's very unfortunate. And part of the reason for this is that the term palliation has a very pejorative and very pessimistic and very negative implication to it to patients, and I suppose to my colleagues as well. And perhaps that's even accurate. I don't want to say no, but that's still an unfortunate thing. But that carries over into its use also in treatment, which is in the 1950s when chemotherapy was starting up, particularly for solid tumors. There were 2 kinds of chemotherapy. One was curative chemotherapy, and if it wasn't curative chemotherapy, we referred to the other type of chemotherapy for patients, say, with metastatic disease as palliative chemotherapy, because at the time, chemotherapy for metastatic disease was basically not very good. And so the best one could hope for was that it would make symptoms better, make the patient feel somewhat better, perhaps improve quality of life. So it was given the term palliative chemotherapy. We stand here today, 60 years later, and we are still using the terminology palliative chemotherapy for any chemotherapy, which is non-curative. Now, 60 years later, I think all of us can agree that chemotherapy has moved forward a great deal. Many kinds of what I'll call palliative chemotherapy are much better than they were in the 1950s. Many diseases, breast cancer, colon cancer, multiple myeloma, chemotherapy for them has, if not curative, at least it's very much life-prolonging chemotherapy. People live years with metastatic disease. So to continue to use a term like palliative chemotherapy for that kind of treatment is really giving it a much more pessimistic and pejorative implication and assignment, which I think for a patient is a very negative thing to do. And I think we should move away from using that terminology in that context now that we're now that it's no longer a terminology that really applies. Let me throw the gauntlet or the I don't know, but what do they say in the Olympics? I'm giving the baton to Chris and let him say a few words about this. Chris?
Thank you very much, Alfred. It's a pleasure to meet you, albeit virtually. Alfred and I have discussed this issue over some time, but not actually met. So I'd agree with everything that Alfred said. And I think during the 50s and 60s and into the 70s, the use of chemotherapy was quite difficult. Patients with metastatic disease had a very difficult time. But interestingly, at that point, there was relatively little, unfortunately, relatively little discussion with the patient about what we could and couldn't do. And although when I was training 35 years ago, we certainly never sought to mislead patients, there was a school of senior oncologists at the time who would tell patients that things were going to be okay, would allow the patients to maybe have a more optimistic outlook than was perhaps likely to be the case. This changed during the 1980s when there was a move amongst some of our colleagues to be much more honest with patients and admit the limitations as to what we could do. And in that context, the use of the term palliative chemotherapy at that time was quite useful because it was a recognition that we couldn't work wonders for many of our patients with metastatic disease. But as Alfred, that admission was actually quite controversial. I remember being at a meeting some 30 odd years ago when a very senior oncologist said she thought it was outrageous that we admit to patients that we couldn't cure them if they had metastatic disease. But now I think we are much more transparent, we're much more straightforward with patients. But what has changed now is that most patients with metastatic breast cancer spend a significant length of time, I know this is a simplification, but living with their cancer rather than dying from their cancer. Or certainly that would be our aim. And in that context, where certainly for people with metastatic breast cancer, where they may live with their cancer for several years, using the term palliative in that context doesn't quite feel right. It has that association with palliative care, but also we use the term palliative in our clinic letters. And of course, increasingly these days, we send out our patients copies of the clinic letters. So patients are seeing a terminology which may confuse them. So certainly I would favor as thinking of metastatic chemotherapy, and it is generally metastatic disease, as being a non-curable chemotherapy, non-curative chemotherapy. I wouldn't, if you like, want to outlaw the term palliative chemotherapy, because there does often come a time when patients have exhausted a number of lines of treatment where there is a decision whether or not chemotherapy is medically appropriate or whether symptomatic measures may be better. And there may be situations where chemotherapy may be seen as on a par with analgesics or antiemetics to control symptoms. And perhaps if we changed from the non-curative to the palliative notation for chemotherapy, that would also be a prompt for us to make that transition towards palliative or supportive care, and to acknowledge that that was the phase of the illness that the patients had now reached. But this is something that we've discussed. We're just keen to have a wider discussion. I did look before coming here at our chemotherapy, our electronic chemotherapy prescriptions, and it gives the prescriber options as to what the intent of treatment is. And the options that we have are curative, palliative, non-curative, disease-modifying, and radical. And I think that's unnecessarily complicated, and that we maybe could find a terminology that we could agree on as obviously with patients, carers, and healthcare providers, that was a little better reflected the type of care that patients hopefully experience these days.
I would add to that so my proposal, in the paper that I wrote, was that we categorize it into three categories, which would be curative, which we all understand, which would perhaps also include adjuvant therapy, neoadjuvant therapy, but also, and that we subdivide for metastatic disease into life-prolonging therapy and palliative chemotherapy. I would agree we should keep palliative chemotherapy when it's really being used for palliation, as opposed to, for the most part, life prolonging. But also it makes it more transparent rather than vague and ambiguous. So that's what I would, again, if we talk about radiotherapy, for example, we sometimes use radiotherapy as palliative radiotherapy. For example, when someone has a bony metastasis, which is painful, there's no implication that it's curative or whatever. It's really purely, we use the term palliative radiotherapy in that context, and I think that's a very clear, accurate, and appropriate terminology, and we should use it in chemotherapy in the same context with the same terminology. If I may, let me switch to another example of ambiguity, I think, or a misuse of the term. And again, this one I haven't thought through that much, but I'll throw it out to the crowd and maybe to Chris. Again, to comment on, which is ambiguity in the term metastasis. Again, another term that we use all the time. It strikes, I think it's a term which is obviously a very concerning term when a patient hears it, a patient who understands the term and what its implications are when they have this disease. But again, metastasis, of course, is spread of the tumor away from the primary site. But again, we use the term metastasis in two contexts. One is metastasis to distant sites, liver, lung, bone. I'll use it here in the context, let's say, of breast cancer, since I didn't realize that this was going to be a breast cancer conference, but obviously that's as good as anything else. But again, we also use the term metastasis for spread to local lymph nodes. So if a woman has spread of her breast cancer to her axillary lymph nodes, and in which case she's, let's say, stage 2 as opposed to stage 4, the same terminology is used by the pathologist in their reports. So that's called metastatic spread to lymph nodes, the same term. Now, if a patient reads their pathology report and sees that they have metastasis to lymph nodes, if I weren't a sophisticated woman, so a sophisticated layman, and I saw that terminology, I think that would strike terror into my heart to see the word metastasis being used there. But the truth is the implications are much less severe. Not that they're good necessarily, but they're not the same as metastasis in the way we normally think about metastasis. So I think, again, that this is an area where we really have to dichotomize the term metastasis into two different terms, something that and to restrict the term metastasis to distant spread or to stage 4 disease, where we understand it and its implications as being ominous, and to give a different terminology for local metastasis to lymph nodes, where it's really a much less severe problem. And I have not yet, I'll be honest, I have not yet come up with a term to use. I don't know what term we should use for local lymph node, or I guess spread is a term that's used sometimes, but I'll leave it to Chris or to someone else here to come up with a term or to think of. But so again, I'll pass the baton back to Chris again.
No, I think that's an important and relevant point, because again, in the context of breast cancer, when we're talking solely about spread to the local lymph glands, we're hopefully still in the potentially curative setting. Whereas when patients have got more widespread metastasis, we're invariably talking about non-curative treatment. So it's a black and white situation in many ways in terms of the nature of the conversation with patients, and I can imagine it being difficult for patients to reconcile the use of the word metastases in these different ways. As you say, I think it's the difficulty is that they are both metastases. It's the addition of the word distant, isn't it? And I'm not sure whether that makes it clumsy or whether we'd be better using the word spread, as you say, for the more local disease.
Can I intervene at this point? Because unfortunately time is our enemy, and I'm aware that Mike Dixon has to leave pretty promptly. So Chris, is it all right if I bring in Mike?
Of course.
And then we'll continue this discussion in the Q&As at the end, because it's very important, clearly. And I'm sure there'll be a lot of interest. So Mike, can I hand over to you, please, for your talk, which is the last word, post-COVID issues and breast cancer moving forward. Are you on mute, Mike?
Hold on, can you hear me now?
Yes, thank you.
Sorry, I've got so many things on my screen at the moment. Let me just, I've got some other garbage come up now. Send large files. I'm going to try and get that off my screen. Just let me, right. Just suddenly got WinZip wants to come up and take over my screen. I don't want to, I'm trying to share my screen, and it's wants me to buy WinZip in the middle of my my talk here, which is crazy. Let me try again, see if it will let me, right. Can you see my screen?
We can.
Right, okay. So I just wanted to, we've had a tough time in COVID. I want to talk a bit, I was asked to talk about a bit about the voluntary sector. So, you know, the impact of COVID on breast cancer services has been significant, and not necessarily for the right reasons. And, you know, we're all going along doing lots of cases, and then suddenly COVID came along, and you see this is like what's happened to the economics and what's happened to all the cases. And I was kind of surprised, shocked, and really disappointed that, that there was, I have to say in Edinburgh, we stopped nothing during COVID. We've continued regardless, and we've had no problems. But ESMO said that low priority groups were follow-up of patients at high risk of breast cancer, so these could be literally shelved for a while. Psychological support visits, and of course, that was transferred to telemedicine, but of course, many doctors actually weren't available to these patients for psychological support visits. They stopped population breast screening. We weren't allowed to do any breast reconstruction with flaps and implants, although we continued to do some implant reconstruction in Edinburgh. The plastic surgeons didn't want to do anything. I actually had to record a series of videos for Macmillan telling patients why they wouldn't be getting their reconstructions. We weren't allowed to do risk-reducing surgery. And they were even saying that low-risk groups were elderly patients with ER-positive breast cancer. You could just keep them going on letrozole. We often put a lot of these patients on letrozole for a while anyway, and patients with DCIS. So it struck me that there's a lot of groups here that they consider low priority, and that really we could almost ignore these patients. And there are consequences of that. This is actually work from Croatia. And you see here that this looks at a number of patients they were seeing monthly. And you can see here, this is there's a red dotted line, averages things out. The blue dotted line is what they were doing normally. So they were at a slow, steady increase normally, but you can see here, it's quite marked shift down in April, May, in the first lockdown in Croatia. And you see by the end, it was, you were getting more and more patients referred. Overall in the UK, there's been a 15% reduction in, this is actually a study, another European study, 15% reduction in breast cancer cases seen in this European centre during COVID. And sadly, they were seeing patients with larger tumours, greater numbers of involved lymph nodes, more de novo stage 4 disease. An increase in patient delay was really due to that fear of transmission and lockdown. We had a lot of patients, even though we were seeing normal people in the clinic, a lot of them were panicking about coming in. We almost instilled this sense of fear in people. The impact on breast screening, according to Breast Cancer Now, there's more than 900,000 fewer women were screened in the year up to March 2021. And that reduction in screening led to a 39% reduction in the UK in breast cancer diagnoses. Of course, what we found out is that COVID and breast cancer don't really interact. Breast cancer patients had less complications and lower mortality than many other groups in the cancer with different cancers. We didn't see any excess complications, but sadly, treatment was amended. And the good thing is that the treatments that we were giving, it was clear, had no impact on COVID infection rate or complications. And it's intriguing, during the whole time of lockdown, none of our staff developed COVID. Since we've come out and got Omicron, loads of people have had it. But during the time when everybody else was locking down and doing nothing, we were gaily carrying on. And we never run into any problems, and neither did our patients. And we shouldn't have changed our approach to treating patients. This is a sad news, looking at the impact of COVID-19 on breast cancer mortality. And I think one of the most depressing aspects of COVID is that the people who were leading us were blinkered. They saw COVID deaths and they had no idea of the other deaths. And they didn't look on the shoulders of giants like the man who saw the apple falling from the tree, Newton. You know, you've got to look beyond and above what's in front of your eyes. And this study from the United States, by 2030, their models predict there are 950 excess breast cancer deaths related to reduced breast cancer screening, 14 deaths related to delays in diagnosis of symptomatic cases, 151 deaths related to less use of chemotherapy during COVID, a total of 2,487 excess deaths, or roughly 0.5, an increase in the deaths from breast cancer of about 0.5%. And this looks at the different numbers of deaths that they would be expecting up to 2030 above. So this is just skip screening. This is skip screening and delayed diagnosis. And this is the minimal effect of not having so many patients getting chemotherapy, because these were mainly the ER positive patients. And sometimes you get it wrong, and I don't know if you can hear the sound.
What O is the generic word for any living animal or plant, including bacteria and viruses?
Orgasm. Oh.
So I don't know if did you hear that?
Just about.
Good. So what he said was, what O is the name for any living organism or plant? And he said orgasm. And of course, it should have been organism. And that's the fact is, we really got it wrong. the thoughts of Macmillan is that there are 50,000 missing breast cancer diagnoses, and the government must act now to tackle the backlog. And we must ensure that this doesn't happen again, and never again should be the forgotten sea. So the fallout for us and for many units is a backlog of patients to be seen. There's increased wait for clinic appointments. So we aren't seeing patients in many centres for 4 to 6 weeks. There's delays getting reporting and scans and pathology because actually the people in labs are off. And many people have left because the stress of everything that's happened has actually been too much for them. Huge backlogs and reconstructions and revised ops. Increased demand, but there's no increased funding. We've heard the government plan out what we're going to do, but I don't think we've actually heard anything that's actually going to make an improvement. And of course, there aren't enough staff. There's so many jobs that are available, and we haven't trained enough people. We haven't planned. And rather sadly, and I see it every day, I've never done any private practice. And it's really sad that patients now, patients who aren't privately insured are going to the private sector to get their lumps diagnosed. And then the problem is what happens when they've got cancer. They then come back in to the NHS system, and that has an impact on NHS patients because they get bumped further down the line in many centres. And one of the things that's been very clear during COVID is the voluntary sector were themselves hit, but actually so many more patients needed information, support, because they had no psychological support because the psychologists weren't there because they weren't working. And against this, you need to understand that we have, sadly, a failing NHS system. I've worked for the NHS a long time, and I've never seen it in quite as big a mess as it is now. Let's look at the impact of the COVID on the voluntary centre. So this looked at, as your financial position deteriorated, this is 1 month during COVID, as the financial position of the voluntary organisation, 697 respondents, as it made worse over the next month. You see 39% in this COVID period, their financial situation deteriorated. The range of service you can offer over the next 6 months, over 40% were saying they've been able to offer decreased services. The financial position over the next month, you see it deteriorate. Demand for services, you see this mismatch between decreased revenue and increased need. And this is really the sad thing is, what's the likelihood of your organisation no longer operating this time next year? Very unlikely, quite unlikely, but very likely and quite likely. And we see the Breast Cancer Haven, quite a few breast cancer voluntary organisations are either no more or have had to make massive changes. And the expected impact of COVID on delivering objectives next year, significant impact, 37%. So what is the future? Well, we need these voluntary organisations more than ever. And somehow we need to get them back on their feet. Somehow we need to get all these groups funded again. You see here the Breast Cancer Haven down there, they're in trouble. Maggie's and the secondary breast cancer group are in here, should be in here somewhere as well, because they're very important. And so we need more and more people to help, because volunteering is a superpower. We have to get innovative. I thought this was very good. Wear it pink. Bet you didn't expect to see this pickup truck is wearing pink, and we didn't. But that's what we need. We need innovative and new thoughts. We need. We've got the voluntary sector plays such an incredibly important part. They're filling all the holes in at the moment because there are many holes in the NHS system. Everybody will have their own list of the roles that the voluntary sector plays. They lobby on behalf of patients to get more money, and we need more lobbying than we ever have because the system is in real trouble. Provide information and advice, work in partnership with the NHS to provide needs. And they continue to improve outcomes through funding research. So somehow we have to, in combination with the voluntary sector, get through this difficult period. But we've got this huge backlog. We don't have enough doctors. We want more and more of the voluntary sector. And of course, in many of the voluntary sectors provide all the hospice care as well. So I think, Houston, we have a problem.
And like that, he's gone.
Thank you very much, Mike. A very sobering but important talk, and appreciate that. So we're fighting against the clock now. There's a couple of questions that have come in from patients who appear to be quite desperate to get some kind of answer. So I'd like to just start with these first. And this is the panel, Chris and Mike and Alfred. And I think, Chris, you've probably been prepared for these. One of them is from a lady who's asked twice about using B17 and turkey tail mushroom extract. Now, she happens to have lobular breast cancer. I know you can't really discuss about individual patients, but have you got any particular thoughts on turkey tail mushroom extract and B17?
I don't. These sort of requests and discussions come up quite frequently with patients. The concerns that I have are, I guess, firstly, that in a number of cases, these can be quite expensive, and I'm concerned if something for which there really isn't any substantial evidence is being used as a means of making money. And I think there is always the concern that if we say that they're safe because they're natural and therefore they don't have an effect, it's difficult to marry that up with them having a biological effect on the cancer. And if they are interfering or changing our metabolism in some way, then clearly there's the concern that this may be negative rather than positive. And there have been some isolated examples where that has been the case. So I tend to be very cautious. It's a different question, but one that I've worked with quite closely around the use of cannabinoids in cancer. And there's a huge literature on cannabinoids, but when you drill down into how much of that is actually substantiated or has been described in an accurate way, a lot of it is potentially misleading. So I tend to be rather wary.
Thank you.
So perhaps I could comment briefly as well.
Because,
I did a lot of work in trying to find out what alternative therapies are beneficial and what aren't. And in fact, we even sort of Chinese medicine. I was involved with people in the United States where they actually took Chinese medicine, and because they tend to be groups of things and even when you dissect out and look individually at the individual components, it's really very difficult to show a benefit. I also think it's really important not to confuse the fact that there's a lot of literature and a lot of information on these drugs from supporters and with evidence. I'm somebody who is completely open to everything out there, but the studies that I've seen show that if you look at the survival of patients in relation to their diet, it's a U-shaped curve. And the people at the bottom of the U who do best have the best balanced diets. And when you look at survival, the difference, people have an excess of something or a lack of something. The studies, they've looked in fairly great detail about diet, of not being able to show that taking something that's not normally in your diet to excess, or reducing something from your diet that's there, improve outcomes.
Thank you. That's, again, really helpful. Thanks, Mike. Right, and another lady has asked, she's got secondary breast cancer, and she's asked a series of questions. The first one is, Why are invaded lymph nodes not always removed? The second is, why don't you do a full body scan, including the brain, from the beginning? Because there might be metastases that they can't see. She's had an experience where her PET scan missed multiple areas of bone metastases. She's asking, how can that happen? And she's been told to have a CT scan, and how can that show up metastases, whereas the PET scan can't? So that's a group of questions, if somebody can come back on that.
Mike, do you want to take the lymph nodes?
Yeah, so like the patient at one time, I was convinced that if you removed all the lymph glands, they would do better involved lymph glands. In fact, study after study after study has shown that whether you remove some or all the lymph glands, surprisingly doesn't make a difference. Now you say, well, how does that, leaving disease behind, how does that work? Well, actually, in patients with cancer who's spread, the body in some of the patients actually copes with the cancer cells for years and years and years. We know that because some people recur 20, 30 years later, and that's been in, that those cancer cells have been there. So actually it turns out that leaving some of the lymph nodes is not always a bad thing. And sadly, there's this belief that if you remove all the cancer you can see, that's going to improve the outcome. And that makes complete and total sense, but actually it's not being borne out in studies. So the American study where they did a central lymph node biopsy, if the nodes were positive, they just left the axilla alone. Those patients who had all the lymph nodes removed did no better than those whose nodes had some nodes left. So it's a conundrum. We don't really understand it, but the fact is that radical surgery, doing more radical procedures, has never been shown to improve outcomes.
And at least part of the problem, of course, Mike, is that what is a problem, what is lethal for most patients who we lose with metastatic breast cancer, is that they had invisible occult metastatic disease when they were first diagnosed. And that doesn't go away by taking an extra lymph node, unfortunately.
That's true.
The question about the different types of scan, I think it reflects the fact that these are, as I said, different types of scan. CT scans are quite good, are probably the best in terms of the granularity. In other words, the amount of detail that you see if you want a scan to look at much or most of the body. PET scans don't show as much detail, but what they can be useful at is if the CT scan or another scan has shown a shadow and we're unclear whether it's cancerous, because cancers tend to gobble up sugar. If you do a PET scan with a radioactive sugar, then the lump that is cancerous is likely to light up because it's gobbling up the sugar. The lump that isn't cancerous is less likely to. But the amount of detail you get in terms of how tiny the lumps that you see are, that isn't as good with the PET scan. The other type of scan that women with breast cancer, metastatic breast cancer, may have are bone scans. And these, again, are injecting a radioactive tracer, and that radioactive tracer homes in on areas where there is bone damage. Now, that in somebody who's got breast cancer, that may well be due to bone metastases. But if you have an injury to a bone, that can also show something, an increase in uptake. So these scans need to be used in their particular situations and depending what the particular question it is that we're looking to answer.
Thank you. I just say that you know, if your cancer's not happens to be gobbling up glucose, if it's not particularly active, then it won't show up on a PET CT. So you can see, as Chris says, not one test is good for everybody.
Thank you, that's really helpful. Now we're in sort of minus time, but for maybe the last couple of minutes, I'd like to go back to Chris and Alfred's talk, and it's kind of, where do we go from here? I mean, I think the points brought up in that talk were excellent, and a lot of the chat comments were coming up with similar approval, really. So if we're not going to call it palliative breast cancer, how do we make that change? And Chris and Alfred, do you have any thoughts on, you know, how we can make this happen?
Well, Alfred has published a seminal paper on this about 2 or 3 years ago. I can't remember how I came across it, but he articulated many of the thoughts that I'd started to have. So I think Alfred and I had decided that following this, that we'd look at how we might take this further forward in terms of whether we canvass patient groups, whether we canvass our colleagues, and look at how we may make this change. It is largely coming from the use by the medical profession. So we would value people's, the public's perspective on this, but I think it would be the medical professionals who we would need to convince to change. Alfred.
That's great. Sorry, Alfred, go on.
No, that's true. I mean, I don't know exactly how you get people to change their language or to change terminology exactly. It's by utilizing it in papers, in the literature, and then people will adopt it more as time goes by. That's a slow process. I think people don't like to change the words they use so easily. It doesn't happen. Sorry, it doesn't happen overnight, but we will say life changes, so words change too. So we'll see what changes down. I saw on the chat line, someone said that they've used the term secondary for second primary breast cancer, contralateral breast cancer, for example. That's what I thought when I first heard someone refer to it. So that's also an ambiguous term as well for me, at least it was for me. And so lots of things are ambiguous sometimes.
I'm so sorry, guys. We could carry on talking for ages, but it's now coming up to 3 o'clock. So first of all, I want to thank Gerard and Pink Ribbon for organising this conference, and he always manages to get excellent speakers, and he has certainly not failed this time. I also want to thank Pfizer for sponsoring, and very much thank Anna and James for all the technical help, which has been amazing. Thanks so much to the speakers. You've all given up your time and really produced some very interesting and excellent talks. And thank you to all the participants who have also really connected. There's been so many things on the chat, and I'm hoping people can go to the chat and look and make connections with each other, because I think there's a lot of useful things that can come out of this. Gerard, can I hand over to you?
Well, not really, Kath, because I think you've summed it up brilliantly there. I mean, thank you to absolutely everybody from contributing from all over the world. I mean, we're happy to help promote any of the questions, points, issues raised today. For example, the terminology point at the end. If we want any input from the patient community, then we can do that. Chris and Alfred will pick up the baton there a little bit if we can run for half a bend on that. But apart from that, just to echo, thanks to all the brilliant speakers. Thanks to Dr. Kay for chairing so excellently as always. And thanks also, I guess, to every single attendee, above all, for coming and spending and sharing a little bit of time this afternoon. And I'll just echo that thanks to Anna and James as well on the technical side.
Thank you.
And God bless and goodbye.
Everybody.
Thank you.
Ciao.
Ciao.
Arrivederci.
Arrivederci.